Hi, everyone. All right, y'all. So it is right at noon. So we will go ahead and get started. I'm sure we'll have a couple more people trickle in, but we will go ahead and get this show on the road. So for those of you who do not know me, I'm Aspen Drude. I manage our Center for Rural Health and Nursing here in the College of Nursing at UTA. And so I'm going to get us started with some housekeeping notes. Right, can you see my screen? Great.
Yes.
Okay. So today's seminar series is going to talk about the critical access and rural emergency hospitals. It's going to talk about Texas and a national overview. And Dr. Suzanne Daly is going to lead us in that venture. It is going to be from 12 to 1. This activity is being recorded, and I'm actually about to start that recording now. Oh, it's already recording. I lied to you. I'm sorry. Teams changed their webinar viewing, so I guess it starts recording as soon as we start. So perfect. So it is now recording. A quick disclosure to our learners. So no individual with the ability to control the content of this activity has any relevant financial relationship with ineligible companies to disclose. This activity received no commercial support, and the University of Texas at Arlington's CAHs is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. Our learning outcomes for today, participants will report an increased knowledge of the program designations for hospitals in rural areas as evidenced by 90% of participants describing at least one expected change of enhancement in their professional practice based on information learned during this activity today. Today's seminar series is offering one contact hour. You do have to attend 100% of the presentation, and you have to complete and submit a post-activity evaluation. Please give Sharon up to 2 weeks for these to be emailed to you. She will send them via, like I said, email, and the link in the QR code is going to be provided at the end of the activity. I'll put the QR code up, and I'll put the link in the chat. If you have any questions about that, you can either email myself or Dr. Blackerby. Her email's right there. And my email is aspen.drude@uta.edu. So if anybody has any questions. Okay, so now that we are done with that piece, I'm going to pass it over to Dr. Daly. Let me stop sharing. And thank you so much for being with us today. We're really excited to hear what you have to say.
Thank you. I'm excited to be here too. I'm going to share my screen. Hopefully I will do it correctly. And see if I can get my slideshow going. Sometimes my slideshow is a little bit laggy because I've got some big maps in there, but hopefully you can all see my screen. So today, we're going to talk about critical access hospitals and rural emergency hospitals and look at Texas and a little bit nationwide as well. And I really enjoy talking about both of these topics. I have really come to enjoy rural healthcare, learning about it, talking about it. So I hope you guys will enjoy the presentation and come away with learning a few things. So today we've got 4 objectives. I'm going to provide an overview of the Critical Access Hospital Designation Program. We'll take a look at critical access hospitals in Texas, comparing those to non-critical access hospitals in Texas. And then we will switch and talk a little bit about rural healthcare and jump into looking at an overview of the Rural Emergency Hospital Designation Program. And then we will finish up with looking at rural emergency hospitals both in Texas and in the United States. Oops. Like I said, I'm sorry, my screen is a little bit slow moving. Oh, okay. So a little bit about the history of rural hospital closures. Back in the 80s and early 90s, we were seeing a significant number of rural hospital closures, over 400. And there was concern at the time that Medicare PPS, which was established in 1983, might be negatively affecting the financial health of rural hospitals. I'm sure most of you know this, but PPS is the Medicare payment that's predetermined fixed rate as opposed to a fee for service payment scale. So at the time, or I guess in the decades since, there have been several federal designation programs that were created with the aim to provide financial support and stability to these rural hospitals in an effort to prevent these closures that were happening. The federal designation programs that we have seen since 1983, the Soul Community Hospital Program, Rural Referral Center Program, um, Medicare Dependent Hospital Program, Critical Access Hospital Program, the Rural Community Hospital Demonstration Program, and then also the new Rural Emergency Hospital Program. There's also the Disproportionate Share Hospital and Low Volume Hospital Program, which are more payment adjustments as opposed to designation programs. But all of these have been established in an effort to slow and prevent rural hospital closures. Unfortunately, we're still seeing rural hospital closures, but I'm going to start with critical access hospitals and talk about their sort of that time period when critical access hospitals were, when that program was created. And then we'll switch into a little bit more talking about the rural emergency hospitals. The Critical Access Hospital Program was established in 1997 as part of the Balanced Budget Act. Its purpose was to increase access and increase resources for these rural hospitals. And critical access hospitals have continued to be an important component of the delivery of healthcare to our rural areas. Right now, we have an estimated 1,496 critical access hospitals across the United States. I say estimated because there are some differing numbers that I've seen on critical access hospitals, but it's somewhere in that around the 1,400 or so range of critical access hospitals. There are specific conditions of participation. So these hospitals need to be located more than 35 miles from the nearest hospital by primary road or 15 miles by secondary road. They can be declared a necessary provider by the state. Now, that provision was eliminated in 2003 with the Medicare Prescription Drug Improvement and Modernization Act. And I think really since then, we have seen a lot fewer critical access hospitals come onto the scene. But that piece, that necessary provider piece, there were states that would or could designate a hospital as a critical access hospital, even if it didn't meet the mileage requirements. So we do see some critical access hospitals that are maybe closer to hospitals or closer to larger hospitals. So we do see some of those. In addition, critical access hospitals cannot have more than 25 acute care beds. Those beds, all or some of them, can be designated as swing beds as well. They do have to provide 24/7 emergency department services. And in addition to that, there does need to be a qualified medical staff member either on site or available within 30 minutes. And that medical staff person can be an MD, it can be a DO, it can be a physician assistant, a nurse practitioner. It can also be a certified nurse specialist who has emergency training. And one sort of piece of that as well is that the provider doesn't necessarily have to be on site. They can be available to arrive within 30 minutes. That does differ for more the very rural critical access hospitals. That time length can be extended for how long it can take for them to get on site. In addition, the average annual length of stay has to be no more than 96 hours for acute care patients. In terms of regular staffing, so not the emergency department, they do have to have at least one MD or DO, but that person does not have to be on site. There does need to be an RN on site 24/7. And they also do have to have an agreement with an acute care hospital that provides services that a critical access hospital may not be able to provide. And then one other really important piece is their eligibility to participate in the 340B program. I'm going to talk about this again later in relation to rural emergency hospitals. This is a really important piece. And for those of you who may not know, the 340B program is a federal program that allows eligible healthcare organizations to buy certain drugs at discount prices, and that discount is usually anywhere between 20 to 50%. And then those cost savings can be reinvested. They can be used for things like paying for uninsured care or hospital improvements. So that does provide some revenue to these critical access hospitals. And like I said, we're going to circle back to the 340B piece later on when we talk about rural emergency hospitals. So critical access hospitals with their Medicare payments, they receive cost-based payments rather than the traditional prospective payment system or PPS payments. That has been 101% of the allowable costs. So it's what are considered the allowable costs plus 1%. Sequestration, which has taken place, has reduced this to 99%. And so by cost-based, again, we mean providers are paid for the service provided as opposed to the PPS where they're paid a specific amount for a type of service or a period of time. There was a new report out from MedPAC recently that showed that critical access hospitals, that this payment structure for them has helped increase revenue by about $4 million to each critical access hospital. And the way that they came up with this was they figured that the cost-based or fee-for-service payments averaged out to critical access hospitals around $10 million. And if they had been paid on the prospective payment system rate, that they would have received around $6 million. So the difference being $4 million. The estimate is that for critical access hospitals, they are each receiving about $4 million, which is, very helpful in keeping a lot of these hospitals afloat. So across the United States, we have around 114,882 hospitals. Like I said, the critical access hospital number is around 1,496 across the United States, and that gives us about 1.3% of all hospitals in the United States are critical access hospitals. In Texas, we have around 10,584 total hospitals. 99 of those are critical access hospitals, and that gives us 0.94% of all hospitals in Texas are critical access hospitals. The numbers that I have here are from the provider of services file, the second quarter of this year file. So these numbers vary a little bit just depending on which data set you're using. But that's the one that I've used for this information. So In Texas, looking at critical access hospitals and non-critical access hospitals, we can see that over 80% of critical access hospitals are located in a non-metro area, and over 70% are located in metro areas, with nearly half of those in counties with a population of 1 million or more. And this isn't surprising given what the purpose of critical access hospitals is. In addition, close to half of the critical access hospitals in Texas are county owned, whereas about 63% of non-critical access hospitals in Texas are under for-profit ownership. And again, that's not too surprising. So this map shows us where critical access hospitals are located in the state of Texas. The metro counties are in orange, and the non-metro counties are in blue. The data sources that I used, or I should say Wei Yu, who made this map for me, used, is the area health resource file for denoting metro or non-metro and using the rural urban continuum codes. As you all know, there's a lot of different ways to define rural and non-rural, or metro and non-metro, but that was what we used for this map. And you can see from this map that the vast majority of critical access hospitals are in non-metro areas. So looking at some of the numbers, some of the statistics, you can see that the non-critical access hospitals in Texas are the county population for 2020 from the census and the population estimate from 2022. Significantly larger median population in the counties where we have non-critical access hospitals compared to our critical access hospitals. Sort of the total area of the counties is not too much different. You can see that the percentage of population that's white is higher in critical access hospital counties versus the non-critical access hospitals. You can also see percent of population Black is higher in non-critical access hospital counties compared to the critical access hospital counties. Some of the other numbers are a little bit closer. On this next screen, we're looking at county characteristics and looking at more at the healthcare provision characteristics. And these were ones that I thought were really interesting in that you can see, for example, the total number of beds is much different. You can see that the total number of admissions is much different. And what I think is really telling, and what we all know and understand and have felt, is that you see the number of registered nurses, the number of doctors, and the number of nurse practitioners is significantly lower in the counties with critical access hospitals compared to those that are non-critical access hospitals. So I found that to be a very not surprising, but just it's always telling when you look at the hard data. So I'm going to stop for a second and see if anybody has any questions at the moment about the information shared about critical access hospitals before I move on to talk about rural hospitals and healthcare and shift into the rural emergency hospitals.
I think everyone has access to unmute their microphones, but I want to be sure. So if somebody can just let me know.
I will ask a question. So you talk about a critical access hospital As far
Can you
as-
hear her, Suzanne?
Not really.
Can you hear me now?
Just just a little bit.
Yeah, it sounds like your mic's covered a little bit.
I think I have some issue with this computer. I will type in my question on the chat.
Okay.
You can go ahead. Yeah.
Let's see. So I saw the question, how many rural hospitals have gone out of business in the last year? So I'm going to go into that a little bit more as we go further into the presentation. So I will circle back, and if I don't answer the question, we will get back to it. So I think that I'm going to go ahead and go on to the next section, but Aspen, if you could let me know if any questions pop up. I can't see. Oh, I see she's typing. Wait just a
Yeah.
second.
Sure.
Because I can't see the questions or anything
Sure.
pop
Yeah.
up while I'm
I'll
presenting.
keep it. I will keep
Okay.
it up to date.
Okay. I'll just wait and see what she types in. Let's see, except critical access hospitals, there are other types of rural hospitals. Any idea what percentile of rural hospitals are designated as critical access hospitals? That's a good question. I think that I don't know the answer to that because I think some of it depends on how you define rural hospital. Um, so, there are a lot of different ways to define rural, but it would be really interesting to look at, determine what your definition is of a rural hospital and then figure out based on that what percentage are designated as critical access hospitals. So hopefully that answers that. I'm going to go back to my screen and continue on. So in terms of rural hospitals and healthcare, I think we all know that rural patients have an increased vulnerability to acute and chronic healthcare problems. We often see higher rates of uninsured, unemployment, poverty, mortality, and chronic illness in rural areas. And for our rural communities, our rural hospitals are often the only source of healthcare in their communities. So we certainly have many urban areas where there are lots of different ways to access healthcare. Not everybody may be able to access that care, but in rural areas, there's often one place to access healthcare, which might be that rural hospital. So in the United States, we have over 2,000 defined as rural hospitals. Our rural hospitals often have a higher burden of closures compared to urban hospitals. I'm going to see if I can get this infographic to work.
I have dropped both of them in the chat.
Okay.
So if people wanted to click on the links there, they can. But if you can't get it to work, I'll pop it up on my screen.
Can you see it? Because it comes up on my screen, but I'm not sure if it's coming up.
No.
Okay.
I can, give me a second and I'll do it really quickly. I'm going to take over sharing for a second.
Sure.
All right. You should be able to see it now.
Yes. So if you can scroll up just a little bit to where it says the 71%, or scroll down, however you want to say that.
That's
So
okay. I can zoom out a little too.
Yeah. So you can see, looking from 2017, this is from the American Hospital Association, but I think it's a helpful infographic looking at rural closures. So you can see that between 2017 and 2021, the number of rural hospitals, and then also looking at the total number of hospitals. And their numbers are that 71% of the decline in numbers of hospitals were rural hospitals that closed over that period of time. So I'm going to go back to sharing my screen. And in addition to the seeing that infographic, there's also something from the Shep Center, the North Carolina Rural Health Research Program map. And Aspen, I'll have you open that too, and we'll take a look at that.
Sure, I have it open. All
Okay.
right. You should be able to see it now.
Okay, so you can see this is the Shep Center. If you all don't know the Shep Center or know about it, they have a really great, or they are a really great resource on rural hospitals and closures, and the Rural Emergency Hospital program. They've got a wealth of information, and they keep these maps updated, showing closures and conversions. So since 2010, there have been 85 complete closures. So that's a hospital that is completely shut down. And then there have been 66 converted closures. So that's a hospital that has not fully shut down, but has converted to a different type of hospital. And Aspen, if you'll scroll up, and if you move the little slide bar where it says closure year, if you go over to, if you slide it over all the way to 2024, it'll tell us, like, there we go, down at the bottom. So it shows us the number of rural hospitals that that have closed in the last year and last 2 years. You can look at it by year. So to the question of the number of closures that we saw or that we've seen in 2024, there have been 5, according to the Shep Center. And then in 2023, there were 8. So there's definitely been, you can see the closures over time. You can see that there was sort of back in the early 2000s, we had kind of a higher number. That decline, it really crept up in the mid 2000s, sort of stayed fairly high. You see in 2021, that number bottomed out completely. And that, I think, was largely due to COVID money that was being provided to hospitals. And we've seen over the last couple of years, those numbers sort of tick back up a little bit. So we can go, I'm going to go back to sharing my screen, Aspen.
Sure.
So unfortunately, still seeing we're still seeing a number of rural hospitals close. And some of the reasons why we're finding hospitals under a significant financial strain, that COVID-19 money is gone. The sequestration that I mentioned earlier, the 2% sequestration, is fully in effect. So that's money that hospitals are losing. We also have staffing shortages, a lot of increased expenses, lack of revenue, and financial reserves. So those things are all causing significant strain for our rural hospitals. And Unfortunately, these aren't new challenges. And like we discussed, we have in rural communities, our rural hospitals are often the only source of care. So without those hospitals, our rural residents may be without local access to healthcare. And this can contribute to increases for our rural residents, increases in morbidity and mortality. And one of the things that's I've found really interesting in my research is many of these closures are in states that have not expanded Medicaid. So looking at this map, again, we use the closure data from the Shep Center and the Medicaid expansion decision is from the KFF has a Medicaid expansion decision data. So that's where these two pieces of data come from. But you can see in this closure data that a lot of these closures are in states that have not expanded Medicaid. And that does limit and hamper rural hospitals in terms of revenue as well. This is something that the Medicaid decision, Medicaid expansion decision and closures is something I'm interested in exploring more from a research standpoint. I haven't really gone beyond just looking at the surface. So in Texas has 158 rural hospitals. 19 of those have completely closed since 2005. It has the highest number of rural hospital closures in the United States. According to Torch, our rural hospitals in Texas serve about 12% of the population, but they cover care for 85% of the geography in Texas. We have some patients who are over 75 miles from the nearest hospital. Rural areas in Texas have very high levels of uninsured. We see near 30% in some areas. And they also serve a high percentage of Medicaid and Medicare patients. And Aspen, if you could click on or share the Center for Healthcare Quality link, that'd be great.
You should see it now.
Okay, yes. So I really like the Center for Healthcare Quality and Patient Reform. They have a lot of great information. Aspen, if you will scroll to that map that says rural hospitals at immediate risk of closing. So this map is really helpful to look at to see where we have hospitals that are in what the Center for Healthcare Quality and Patient Reform deems immediate risk of closing. And again, if you remember back to the map that I showed with the Medicare expansion decision, a lot of these hospitals that are at immediate risk of closing are also in states that have not expanded Medicaid. I don't know what the correlation is there, if there is any correlation, but it's an interesting finding that I think needs more explanation. Aspen, if you'll scroll up just actually the just stay, you can stay where you are, maybe go back to that the graphic next to it that shows the rural hospital closures and rural emergency hospital conversions. So again, that data is from the Shep Center and it shows our rural hospital closures over time, and you can see over 2023 and 2024 that we have had, fortunately, have had hospitals that have converted to rural emergency hospitals rather than close outright. And we'll go into talking about that in just a second. So I'm going to go back to sharing my screen. Get myself back to that. Oops, Sorry about all the back and forth here. Okay, so one way that we can address these disparities that we see within rural communities is ensuring that our rural residents have access to some level of healthcare. And that's the purpose of the Rural Emergency Hospital Designation Program, is it's aimed at providing financial stability for rural hospitals and a continued access to at least some level of care for our rural patients. So this designation program was created in December of 2020. And it was, like I said, in response to what we saw with these continuing rural hospital closures. This designation allows rural hospitals to get paid by Medicare for emergency department and other outpatient services without meeting the current Medicare definition of a hospital. And the current Medicare definition of a hospital is that you are providing inpatient care. So the purpose of this designation, as I've said, is to maintain this access to some level of services, so critical emergency department services in communities that might not be able to support or maintain a critical access hospital or a small rural hospital. It was part of the reason why this designation program has come about, is to address the concerns over this increase in rural hospital closures. There are 150 that have closed between 2005 and 2019. Over 600 hospitals have been identified as being at risk, and over 300 of these are in immediate risk. And that information comes from that the Center for Healthcare Quality and Patient Reform data that we just looked at. So which facilities are eligible for this program? Well, they have to either be a critical access hospital or a rural acute care hospital, has to have 50 or fewer beds, and has to have been open on December 27th of 2020. Must be located in a rural area or have a rural classification if it was not designated as a critical access hospital. For the purposes of this program, rural is defined as micropolitan and non-core counties using the Office of Management and Budget's core-based statistical areas. If a hospital or if a facility closed after December 27th, 2020, they are eligible to reopen as a rural emergency hospital as long as they meet all the other conditions of participation. So some of these conditions of participation, there's a long list. I'm going to highlight the ones, I'm just going to highlight some of them, but they have to enroll in or be enrolled in Medicare. They have to have a transfer agreement in effect with a level 1 or level 2 trauma center. They have to have a staffed emergency department. The staffing requirements are very similar to those for critical access hospitals. They have to have an average annual length of stay of less than 24 hours. So essentially no inpatient care, no acute care inpatient hospital services other than if they're licensed as a skilled nursing facility. And they are unable to participate in the 340B program. So I referenced that earlier, talking about critical access hospitals and that they can participate in the 340B program. Right now, rural emergency hospitals are unable to participate in the 340B program. And that, I think, has prevented quite a few hospitals from converting. It's a sort of I think, a point of contention. And I think if Congress can change that and include rural emergency hospitals in in 340B participation, I think we will see some additional hospitals participating. These rural emergency hospitals can provide other outpatient services. They're not required to, but they can. And a hospital that changes to a rural emergency hospital can change back. So it's not a binding agreement. They can move back if they want to. And some of those other outpatient services that they can provide, for example, they could provide labor and delivery, but it has to be outpatient services. It can't be a stay of longer than 24 hours. So in terms of payments, they're paid at the outpatient prospective payment system rate plus 5%. Any services that they provide that don't meet the definition of a rural emergency hospital service, those are paid at the regular OPPS rate. They also receive an additional facility payment every month. In 2024, that amount is $276,233.58. This amount is the same for all rural emergency hospitals, regardless of their size or number of patients served. The number does differ slightly for tribal or Indian Health Service hospitals, which are also eligible to be rural emergency hospitals. This is another important piece and part of why we have potentially seen not quite as many hospitals, or I guess not a big jump in numbers of rural emergency hospitals, but states have to establish licensing, staffing, and regulatory requirements before hospitals in their states can convert. There are 18 states that have met these requirements. Texas is one of the 18, and Texas was one of the early adopters of these regulatory requirements. So as you'll see later, Texas had the very first rural emergency hospital. So some of the benefits of converting, conversion preserves access to emergency care and outpatient services for our rural communities. And that's probably one of the biggest benefits that there is to this program. It also provides an opportunity for a hospital to really focus in on just providing emergency department and outpatient services. For rural hospitals, 80% of their revenue is from outpatient services. So in a lot of cases, it might be really beneficial for them to have this very specific focus. The program does also allow rural hospitals to continue to provide at least some level of care in their communities. And that's really important in a lot of ways. I think if you can have some level of healthcare, it may not be exactly what we want in terms of having inpatient care, but if we're still keeping healthcare in the communities, that's important. And there's also the benefit that rural hospitals can still provide some skilled nursing in a separate unit, so that doesn't go away. There's also the possibility of using these increased funds if they do have, if that bundle of money does give them increased funds, that maybe they can expand some services. An example would be something like preventive screening for mammograms. And then there's also the possibility of strengthening those regional relationships between larger and smaller hospitals that could potentially improve rural patients' access to specialized care. Some of the disadvantages that have been identified, there's a loss of services for communities that already face shortages. There's a loss of clinicians who may want to be providing inpatient care. So you may have clinicians in a rural community who leave because they're no longer able to provide inpatient care. We could see backlash from the community. The hospital may be seen as abandoning them if they're no longer providing inpatient services. there's potential job loss for our communities, especially for nurses. And we see in our rural areas that our population tends to be older and higher rates of chronic illness. We don't know what it means if there are no inpatient services for this population. If they have to travel much farther for inpatient services, how does that affect this population? And that's a big unknown right now. There's also the question of transportation to larger hospitals. Are the larger hospitals going to have space? Are we going to have ambulances that are able to transport in rural areas? What about patients receiving care in a timely manner? What about services being performed, duplicate services being performed? What about patients' families? Are they able to travel a greater distance to be with them in the hospital? If they're not, is this going to have any negative effects? And what about if your inpatient care is 70 miles away from where you live? How does it affect the follow-up care? So these are all questions that we don't really know the answers to yet, that have been identified as potential disadvantages of converting. And these are questions that play into hospitals' decision-making about converting. So across the United States, there are about 1,700 hospitals that are eligible to convert to the new rural emergency hospitals designation. 30 have made the decision to convert since 2023. Nearly half of these are in states, again, that have not expanded access to Medicaid, highlighting those challenges faced by hospitals in those states. One hospital that converted in Texas has closed completely, so it's out of the picture now. And then I've got a map that's coming up next to show the rural emergency hospitals across the United States. And not on that map, because of the data that we used, is one conversion in Oklahoma and one in Georgia that both happened July 1st of this year. So here's our map of the rural emergency hospitals, again, using the same data for Medicare expansion decision. The conversion data is from the provider of services files. So it differs slightly if you go to, for example, the Shep Center website. They have a rural emergency hospital conversion map. So their numbers are a couple of different because of our cutoff for conversion was December 1st of 2023. So, but again, you can see where these hospitals are located. And in Texas, again, there's 5 shown there, but we actually only have 4 because one has fully closed its doors. So in Texas, in January of 2023, Crosbyton Hospital was the first hospital in Texas and the first in the United States to convert to a rural emergency hospital. There are 4 additional hospitals that have converted: Falls Community Hospital in February of 2023, Anson General in March of 2023, St. Luke's, which converted in June of 2023, and then St. Mark's Medical Center, which converted in February of 2023, and then closed in October of 2023. So I did just some initial comparisons looking at rural emergency hospitals in Texas compared to those across the rest of the United States. Similar populations. I think you can see, not surprisingly, that the counties in Texas are a lot larger than the counties in the rest of the United States. But as we all know, everything's bigger in Texas, so that's not surprising. You see also the percent Hispanic population is significantly higher in Texas, which again, I don't think is surprising. But we also see higher rates of poverty and uninsured, which, as we talked about earlier, especially with the uninsured, that Texas has some very high rates of uninsured. So that's playing into those numbers there. And again, looking at the county characteristics for some of these healthcare indicators, I thought it was interesting that for the rural emergency hospitals not in the United States, the number of or the median number of registered nurses was a lot higher. And we also see higher numbers of non-federal MDs and nurse practitioners. So just some interesting initial descriptive statistics. This is all data that I plan on digging a lot deeper into, but definitely some initial differences that we see between Texas and the rest of the United States. This map, again, we see in Texas, where we have our rural emergency hospitals. The metro is again in orange, non-metro is in blue. And these, again, the metro and non-metro is from the area health resource file using the rural urban continuum codes. And one of the things I just want to point out that I was kind of confused by when I was initially looking at this is like Crosby County, and Jones County and Falls County are all indicated as metro, but these are very small populations, small counties. But part of the reason why they're listed as metro is for the rural urban continuum codes. They are identified as metro because they are considered as part of a metropolitan statistical area. So even though they are not really metro, that's how they're listed with the rural urban continuum codes. I know that's a little sort of going around and around. It's a little confusing, but that's why they're listed like that. And then I just wanted to show you all looking at the counties specifically. So you can see across these counties fairly high rates of poverty, uninsured, high rates of unemployment, and lower populations. Jones County is sort of the exception to that. And I have down here the Texas average percent poverty, uninsured, unemployment rate, and population estimate. So definitely some small areas, some small counties in terms of population, some high poverty, a lot more uninsured patients, and higher rates of unemployment. And then just a note, I wanted to finish up with St. Mark's and just talk about it briefly. So it converted from a 38-bed acute care PPS hospital to a rural emergency hospital in February of 2023. It closed completely in October, becoming the first and I believe only rural emergency hospital that's closed its doors after converting. It was the first rural hospital closure in Texas since COVID-19. The hospital itself, 18 years old. The closure unfortunately eliminated 50 full-time and part-time jobs in LaGrange. And in that surrounding area, at least 4 hospitals have closed their doors in the last 2 decades. So patients are now having to travel 20 plus miles to the nearest hospital. And just a note about Fayette County, where St. Mark's is located, population about 24,000, poverty rate close to 10%, uninsured rate close to 12%, and located in the area between Houston, San Antonio, and Austin. And that's all I have. I'm going to stop sharing my screen. There's my email address if you have questions. And I'll answer any questions that you all might have.
There is one question in the chat. Did you get to that?
Let's see. Oh, after conversion to rural emergency hospitals, these hospitals are no longer providing inpatient services. That is correct. I mean, I think that they can get around having patients stay for longer than 24 hours if the average length of stay is less than 24 hours. But I think that for the vast majority of these hospitals, the focus is on emergency department services and other outpatient services. You're welcome. Anybody else have questions?
And
I'm
y'all
not sure
have
if I can
access to your, oh, there we go. Perfect.
Sorry. I'm not sure if I can ask this clearly because it's not clear on mine, but did I understand correctly that there are fewer incentives for these rural hospitals, or it's more problematic for them to stay open for OB services because it becomes a potential inpatient situation?
Yeah, I think that's the issue.
Okay.
So they can, as a rural emergency hospital, they can provide those labor and delivery services, but it has to be outpatient. But that is one of there are, I would say probably like 8 or so sort of sticking points that people have, policymakers, et cetera, have brought up as potential barriers for hospitals converting, and that is one of them.
Okay. Interesting. Thank you.
Yeah. Let's see. Do you have any ideas how to temporarily provide access to care in these areas? I mean, I think that that's really difficult. I think that that's the sort of, I don't know if I want to say, because if I think about temporarily provide care, I think that, the purpose behind these rural emergency hospitals is that, to stay open for the communities in some level, to provide some amount of healthcare in these communities. I think it's a good idea. I think that time is going to tell about how it plays out and whether or not, on paper or in the real world, what looks good on paper actually works in the real world. I think that there are definitely some potential stumbling blocks thinking about sort of some of those downstream issues of ambulance transport, and what do you do with patients who are far away from their families? What kind of effect does that have? And I do think that Congress really does need to update some of the conditions of participation. We could definitely bring in more hospitals if you allowed these hospitals to have maybe 1 or 2 beds that could be used for inpatient care. There's a question in here about changes in access to 340B programs for rural facilities. I do think that is really being pushed. It seems sort of deliberate that rural emergency hospitals, that was left out on purpose. So I think those are all ways to hopefully bring in more hospitals into this program. I think one of the other concerns is the flexibility of, again, allowing some OB care or allowing some inpatient care, because that would pull more hospitals in. So rather than having a complete closure, you at least have some basic level of healthcare in rural areas. And that's the idea behind the program. It just maybe needs to be a little bit more flexible. And somebody said, who is at the table to support these hospitals? That's a good question. I often think that rural healthcare is very lost in the world of healthcare. I definitely think that there are people out there who are pushing for support for rural hospitals. Maybe because I spend a lot of time thinking about rural healthcare and rural hospitals, I feel like it's got more attention than it does. But I do feel like there is more attention being focused on rural healthcare these days than there has been in the past.
I have an example if you have time.
Sure.
Our critical access hospital is county supported by the taxes, but and the county pays for EMS equipment, but it does not pay for their salaries or their hourly wages. So the hospital forked over their hourly wages. So that monies, if it is converted to a rural emergency hospital, those wages for that ambulance will probably go to the wayside if it's less than what they're making as a critical access hospital. So that ambulance would be a big issue in transporting those patients out of the county to a higher level of care.
Yeah.
I can see. Yeah.
Yeah, I definitely agree. I mean, I think that that's